Episode 495. Wait, flip that. A crazy revelation I had about trying to fix U.S. healthcare. Today I speak with Dr. Mick Connors.
American healthcare entrepreneurs and executives you want to know. Talking. Relentlessly seeking value.
Relentless Health Value Tribe. In this conversation that follows with Dr. Mick Connors, I had a barnstormer of a revelation. One I have never heard anyone talk about before. Like, ever. It's a major fundamental bottom line, though, about the U.S. healthcare system. An insight that once you see it, you kind of can't unsee it. And don't get me wrong, why this revelation is true, why it is in fact the case, will shock no one. But yeah, we'll get to that after I drag out the suspense just a little bit longer. Okay, so we, the Relentless Health Value Tribe, are committed to fixing healthcare and putting patients over profits. We want to find a way forward to manage a $4.9 trillion sector such that we raise the value of services delivered, meaning reduce or at least hold costs static, while the outcomes or the health gains or whatever you want to call what the patient gets from the spend is realized. The typical formula is outcomes divided by cost equals value. Okay, so let's think about how we measure cost or what we know about cost. And then let's think about how we measure outcomes or what we know about outcomes. And I'm picturing Willy Wonka right now, the Gene Wilder version, when he says, so much time, so little to see. Oh, wait a minute. Strike that. Reverse it. Meme in the show notes. Here's the deal. In American healthcare, we currently measure costs at a macro aggregate level. Most of the time, no one knows what it costs to deliver any given individual service. There is no or little effort at unit cost accounting. Dr. Steve Schutzer talked about this in an episode a few years ago. So that's half of this revelation and undeniably a problem. One of which many of you are probably fully aware of already, but just right. Like if you are running any other business and you encounter like any of the sharks from Shark Tank and you cannot tell them the unit cost accounting, like you don't know what your cost of goods are, the financial discipline buzzer is going to be going off like a fire alarm. But again, I could probably fit around my kitchen table. And I'm exaggerating for dramatic effect, of course, but I might not be far off. Like I could fit around my kitchen table the number of folks who probably could tell me with any degree of fidelity what the costs of service and cost of goods are for spine surgery or pick any other procedure. But if we can't, we essentially have no financial discipline on the cost side, because if it's unclear what the unit cost of anything is, that is a requirement for fiscal discipline. So therefore, you can't have it if you don't have one of the biggest rate criticals. All right, so now let's flip over to the quality side. We track quality, and sometimes we even use the term patient outcomes in this context, but we track it to the 10th of a percentage point using extremely specific, narrow, for example, HEDIS measures like A1C or BP control. But on this side of the house, what do patients actually want? They want whole person health. They want better community health, better population health. But at these roll-ups, whole person health, better community health, better population health, these things are measured by very few, at least with teeth. Dr. Kenny Cole talked about this actually in the episode with him. Health gains arise when all of the risk factors are reduced in tandem, not just one of them. And along those lines, if you listen to patients complain about the health system, once they move on from the cost of their latest doctor visit, you will next hear a long story about how some catastrophe is afoot because their cardiologist won't talk to the ortho guy who said he can't do the procedure until the blood thinners or whatever, and then they can't get the RX for their inhaler. That is not whole person care. And it's going to be a problem on the quick for the patient, for their family, for the community. You see the misalignment. We measure costs in the aggregate, but we measure, in air quotes, outcomes at the service level. So here's the revelation. We've got to flip it like Willy Wonka style. We need to measure costs at the unit level. We need to measure health and outcomes at the whole person, whole community, whole population level. It is fundamentally problematic to talk about our financial woes at the hands of the healthcare sector when prices are rising every year if no one knows how much the service costs to produce. And it's disingenuous, frankly, to talk about amazing HEDIS scores when a community is dying young. To say no margin, no mission, with the integrity really that statement demands, we got to be doing cost accounting at the unit level and measuring outcomes at the patient and community level. And And that is how this whole conversation with Dr. Mick Connors started out, by the way, as a continuation of the No Margin, No Mission series. But yeah, it went off the rails in like T-5 minutes and became, how do we create value in healthcare versus margin that gets siphoned off the top? Today, my guest is Dr. Mick Connors, who is by training an ER emergency room pediatrician. His passion has always been how to get all kids better care. Besides working in emergency rooms, Dr. Connors also worked at for-profit institutions and started a telemedicine company. So he has lots of angles to look at all of this through. I love this conversation. My name is Stacey Richter, and this episode is sponsored by PayerSet and Aventria Health Group. PayerSet is a price transparency company with a mission to create fair and equitable healthcare for everyone. Love that. PayerSet empowers healthcare organizations, employers, and patients with the most complete set of healthcare price transparency data. They benchmark every negotiated rate and claim and deliver the insights needed for smarter contract negotiations and a more transparent healthcare system. Dr. Mick Connors, welcome to Relentless Health Value.
Oh, thanks so much. It's really an honor and a pleasure to be here. I really love your work and your podcast. I've been following you for a long time, so it's a real pleasure to be here.
Let's start here. As we're thinking about margin, if you had to define margin, how would you define it?
Yeah, I think I would define it the same as most everybody else. I mean, it's what's left over after you delivered the services that you want to deliver, right? So is there a way to make something sustainable, profitable, wildly profitable? And we in medicine don't talk a lot about margin, even on the physician side. When you're leading physicians, it's about downstream revenue, how many RVUs you can produce. It's about revenue. We don't do a great job of talking about costs. The difference between the revenue and the cost is the margin. And it's an important concept that most of us physicians don't really get. For example, when I was in hospital administration, the orthopedic surgeons were so excited about the downstream revenue they were creating from a spinal surgery until we figured out that the rods that they were using in the spinal surgery were costing more than the actual reimbursement payment that we were getting. So it was, though it was high downstream revenue, there wasn't any margin. There was actually no margin. It was actually unprofitable. And so there's that, oftentimes that disconnect for us, especially medical folks, of thinking about, we've kind of been addicted to RVUs as value and revenue as value, when in reality, you have to have something left over that's called a margin to make anything sustainable.
It's interesting how you are teeing this up. Many times, I think, especially when we rattle off no margin, no mission, what we're thinking about as margin is all of the money coming in, which to your point isn't margin by your definition, it's revenue. And because, as has been said any number of times on this podcast, there's a whole show with Dr. Steve Schutzer about this. Very few healthcare organizations, clinical organizations, are even able to calculate the cost of any given procedure. So you guys figuring out that the rods cost a lot, like anyone who's been in the private sector for more than 2 minutes is like, what? But it is, It is really unusual for any clinical organization to actually figure out what is the cost of delivering any given care service.
That's always the challenge that we have is one, what is the margin? To your point, one, cost accounting is not part of healthcare, right? Nobody wants to do cost accounting. There's a great Harvard Business Review article from, I think, in the 2010s talking about cost accounting. I mean, we've been talking about cost accounting, but nobody wants to do cost accounting. Everybody wants to drive RVU, drive revenues, move to healthier, wealthier environments, drive more revenue, and then kind of reduce cost that way.
What you're saying makes me think of some health systems spend every dollar they're given. That's a quote from the episode with Shane Cerrone and Dr. Sam Flanders, episode 490, I believe, which puts a little bit of a spin on the term nonprofit for sure. Throw into this on the seller side of the equation, because as we both just said twice already, it's an edge case to find somebody who knows what the unit cost is. But wait, there's more. How many purchasers buy discounts? So not only does anyone not know what the cost accounting for any given unit service is, no one actually knows what the price is either. All I know is that someone chucked 90% into the tilt-a-wheel and said it was the discount, right? So anyone who's buying discounts does not know the price that they're paying. It's very common also, actually, on the seller side to not know what that price is either. So like we've got, no one knows what the bottom line is, the cost of anything is, and it's odd to know what the top line is for any given service. So you can kind of see like how all of this would go horribly wrong, because what winds up happening is the only financial move then is to try to get as much revenue as possible, like in the aggregate, which is exactly what's happening.
If you go to the foundational level, like healthcare is very complex. To your point, there's so much opaqueness. There's so much, whether people don't know the total cost of care or whether they don't want to admit the total cost of care. At the end of the year, there is a spend and there is a cost. And we see the spend just go up and up and up. And people then say, well, it costs too much to provide care. And yet all these people are taking margins out of it.
Yeah, there is an infographic by Andrew Sang showing 27 streams of income in between plan sponsor pays and doctor gets paid. So yeah, maybe no one wants to know what the unit cost is of any given service, because then it would be possible to see how much of the 4.9 trillion is leaking out around the edges into things that sometimes, not always, but sometimes have nothing to do with patient care, nothing to do with mission, nothing to do with outcomes. There is a reason why knowing unit costs is such a very basic, fundamental rate critical of even the most basic fiscal discipline approach, because it's a really powerful thing to know.
Yeah, and I think, Stacey, to kind of the first point is the margin the goal, right? So when we say no margin, no mission, we begin to focus on the margin. So to your point, what we typically do in healthcare is we try to generate more and more revenue. We work harder, we work faster, we streamline, we make things more efficient because we want more revenue. So if we're just focused on margin and then not the unit cost, then it's pretty easy to monetize a sore throat, a runny nose, a kid with a fever, a kid with a broken arm. We simply we don't do an outpatient x-ray anymore. We don't splint them in the office. We send them to the ER. The chronic kid that has asthma shows up. They're out of their inhaler. They're in the ER. We don't necessarily lower cost. But as in the title of your podcast, it's about value. And what is value is margin and mission aren't in the value equation, right? The value equation is outcomes over cost. So how do we switch our focus to how do we improve outcomes and or lower cost? And if we're just in the margin mission game, I worked at private equity. If we can roll up as many things that we can make them more efficient and we create more margin, are we offering value? So that's where the pivot becomes, okay, the value equation is outcomes over costs. So are we improving outcomes and or lowering costs, or are we just making more margin?
Yeah. And again, it goes back to this cost accounting thing, because how are you going to lower costs if you don't actually know what the costs are? So I just want to point out and underline that there's a very fundamental flaw in the pursuit of value. If value is outcomes divided by cost, if no one's keeping track of actually what, from a cost accounting on an individual unit basis, those costs are. Because if all we're doing is doing that math at the corporate systemic level, and if the go-to is then just raise your prices and that's where the, margin is coming from, then the value equation turns into a how are we going to raise our prices next year equation.
If we're consolidating hospitals, if we're consolidating primary care, and we're creating great margins by streamlining efficiency, but we take all that money out of the system without reinvesting in the patient populations that we're trying to serve and the physicians and nurses, et cetera, to make care better, then, those are really two options.
We can be thinking about the margin left over after costs are paid and throw it into two categories relative to thinking about what are we going to do with this money. One is this investor mindset.
Yeah, I think my experience with pediatric private equity, there's a big movement in pediatrics for private equity to come in and buy up primary care. And I think the challenge that the mission that I was sold on was, hey, we've got a high Medicaid population. We want to improve outcomes and lower costs and want to figure out a way to make margin there so that we can get more kids on Medicaid, better care. But in reality, the way that it was set up, when you're thinking only about the margin, is man, how do we buy up as many practices as we can so we can streamline efficiencies? We can do offshore call centers. We can create margin by lessening kind of the expertise and the care and the access, drive revenues so that we can, because our goal is 30% margins, and so that our investors are happy not only now, but in 7 years when we sell to the next bigger fish. And the challenge is, I mean, pediatrics is generally low margin. We are generally poor business people. Why? Because we're more focused on the mission, right? We're trying to be sustainable as a primary care practice. Sure, we do a lot of dumb things from the business perspective because we're investing in doing non-RVU producing things for our patients. But again, if your target is, hey, I really want to grow my salary, I'm going to hire more nurse practitioners, I'm going to pay my physicians less, I'm going to work them harder. You don't have to be the evil private equity. You can be a pediatrician or a CEO or the like, right?
Listen to the shows with Dr. Suhas Gandhi and Vivian Ho, PhD, and Preston Alexander about how health system CEOs are often incented. And spoiler alert, it mostly has to do with growth, i.e. higher revenues and more beds. Very much an investor mindset. Just pointing out that private equity does not have the market cornered on an investor mindset. Just to underline a couple of things you were talking about there. And there was a show with Yashaswini Singh about private equity and how private equity tends to make money in healthcare, which definitely aligns with some of the things that you're saying. You try to buy up as many practices as you can for all the reasons that you said. There's efficiencies that could be realized, but also you create market power. So you can raise prices, but then also you can diminish service offerings. It's interesting that when you were describing things that doctors do, you described it as we do dumb stuff. And I just want to highlight that because if you're only thinking about this from an investor mindset, then it could certainly be considered a dumb thing because it's mission focused, especially if you've got people who are very good at calculating ROI with spreadsheets, and mission is harder to calculate. Outcomes are harder to calculate.
Yeah, I think absolutely. And I think there's a lot of outcomes that rely on, we'll call it the dumb stuff, right? Like it's the non-RVU producing care. It's the after hours phone call that I pick up. It's the text to the parent the next day, hey, how's your kiddo doing? It's the relationship with the local community that is underserved, that has someone there to care for them, but chose to work in a place where if you were a businessman, you would run away. Let's face it, whether we're a physician, a hospital, a private equity, we all can make really strong business decisions that are really undermining the value proposition for most of the patients. And that's the struggle that I've always seen. And I've seen the evolution in the fee for service over the last 30 years, how things have changed where the pediatricians are cranking through 15-minute visits and they don't have time to care for their patient or to do the extra things. I've heard pediatricians say, if I can't bill for it, I don't do it, which is a really scary thing for pediatrics, primary care in general, because if we're focused only on the RVU generation and we know the CPT codes better than we know our families, then you start to run into that, hey, I got great margin or I have some margin because I need to sustain myself, but I've really kind of lost mission and then I'm burnt out and then I'm not seeing the impact of the care I'm delivering. I send all the sick kids to the hospital. We turn a strep throat from $200 in the office to $2,000 in the ER. There's ways to create margin that are just not mission driven. And that's what I've seen kind of the evolution over my 30 years is it's more handoffs, more fragmented, less continuity. And it's great for heads and beds in the ER and ER volumes. And to your point, there's a great classic article that is called The Folly of Incentivizing A and Expecting B. We're incentivizing margins. We're incentivizing, hey, grow margins. But then on the flip side, we whine about burnout and lesser income being replaced. We talk about high cost of care, families, like being a patient, like good luck, right? I mean, it's when I've been on the patient side, it's amazing to think this is what care looks like from the patient side of the thing.
What's being highlighted to me in this conversation is a doctor wrote in a comment. He wrote, physicians can't save this system with empathy alone. That is so true here, because if the only mission that winds up slipping through the cracks and I'm exaggerating for purposes of clarity, but really, if the only way mission really truly happens is because a doctor has enough empathy to ignore the financial incentives and the structure of their organization and their own personal compensation. And I've heard of people getting yelled at for helping patients, wasting time doing dumb stuff, as you put it.
The way the system is set up, I'm incentivized to see more patients and do the things that are targeted towards selecting out a healthier population. I'll just be honest. That's why it's so easy in this world of anti-vax and everything else to create mistrust. Like you guys are fee for service, like you're on commission. No, that's never been the mindset of any pediatrician I know, but it's an easy way to corrupt kind of the system in that everything has got to be a margin because that's how folks get paid. And what we really need is outcomes-based care because it's really the value proposition, as we've seen with private equity and pediatrics, can easily be gamified with HEDIS metrics and immunization rate, pay for performance, diluting care, doing more visits. If I want to grow, if I want to make the most money, I'll pick on pediatrics. As a pediatric primary care doc, I'm going to get the healthiest population. I'm going to see them very quickly. I'm going to refer anybody who's sick to specialists in the hospital. I am going to fill my office with well visits. Sick visits, I'm going to refer to urgent care, the ER, because they're going to slow me down if I can't fit them in quickly or if they don't fit into my schedule. I'm not going to be focused on anything that's complex or chronic. And I'm going to have a harder time with things that need continual care because I really just need to get my CPT codes. I need to do my well care. But also, gosh, if my patient population is a 50% vaccination rate and I move it to 55%, I don't get any bonus, but the practice that's at 85% this year and 85% next year gets a bonus. Chronic complex disease, the fundamentals are just completely ignored in the current environment where it's just revenue. Like, this makes no logical sense. My hope, even though I can't get anybody to do this, is to say in primary care, okay, you have 1,500 patients attributed to your primary care office. This is what they spent this year. Right? This is the total cost of care for your patient population. What if we reduce that spend by 1%, 2% next year? And how are we going to reduce that spend? We're not going to reduce the spend by referring more kids to the ER, admitting more asthma patients, not, taking care of obesity, right? We're going to have to look at the outcomes of our patients, and we're not going to focus on the 80% that are healthy. We're going to focus on the 20% that aren't healthy or that have other social determinants needs. That's the idealistic Dr. Mick nature of how do we get to outcomes-based practice.
You said a number of really interesting things. One idea I'm really drilling in on, when you start to pick apart outcomes and you try to drill it into these distinct process types of things, which is what we have tended to do, thus spawning the measurement industrial complex. What winds up happening, that can get gamed really fast. Listen to the show with Rebecca Etz from the Green Institute about how to evaluate primary care, because one of the things that she says, it's all about trust. The more a patient trusts their primary care doc, the better their outcomes. So she's like, measure trust, because the second that you start measuring primary care performance based on biometric anything, those organizations who are rich enough to afford the consultants and the fancy EHR and the coders and whatever, those organizations are going to wind up doing better. Whereas doctors who may not have all that fancy stuff, and I'm talking about independents primarily now, who actually have trust with their patients, may actually wind up with better patient outcomes, are the ones that winds up inadvertently not doing well. We split everything down to the unit and we don't roll everything up to, as you said, the population level or the community level or even the patient level, if we're being honest here. So what we're talking about is, hey, maybe we should flip that. On the cost side, let's drill down to the individual service level. Let's really do cost accounting. Let's really understand what any individual cost is. And then on the mission side, let's worry about the whole patient, shall we? Or the whole community or the whole population.
Right, absolutely. I think it always comes down to the 80-20 rule. We've lost sight of as the 20% that are driving a lot of the healthcare costs, and not through any fault of their own, typically. I have kids that are in the ER for a school note because they're going to get kicked out of school because they can't get into a primary care office. It's just kind of crazy town. But if we targeted the 20% and said, hey, who are the kids that need healthcare the most? Who are the kids or the families or the patients that are the outliers that are really driving high costs, we would turn everything on its ear, right? I mean, we would not function in the way that we function now. Let's not even be idealistic about mission. Let's say, hey, we're really smart people, make money by keeping kids out of the ER, out of the hospital, or lower that cost. I think the fundamental question is do we really want to lower costs? We all are listening to WIIFM. What's in it for me? We all are there. I've been there. I've made plenty of mistakes where my mission didn't really overtake my margin desires, or I helped families get a higher bill because we were able to charge a facility fee and that helped the overall revenue. At the end of the day, there's just no incentive for us to do the non-RVU, to do the better care, to take an extra 20 minutes with a family, to follow up, to do all those things that make us such better physicians, happier caregivers, happier nurses. It's just becoming, if we get a U.S. News World Report high ranking, families are going to trust us. They're going to believe that, even though I can tell you, having worked at lots of different places and the rankings don't measure up with the quality of care that I see delivered.
The first thing that you talked about was like, hey, let's focus on the 20%. And you gave a number of different examples. And I'll tell you who you sounded like, a doctor. Mm-hmm. This goes back to Dyad leadership and just the vital importance of it. There has to be enough doctors in actual leadership positions. And we're not talking here about doctors who have hung up their stethoscopes and now don't see patients because, and you mentioned this to me in an earlier conversation, but these days a physician can make a whole lot more money as an administrator not seeing patients than seeing patients. Dr. Tom Lee, the founder of One Medical, also talked quite a bit about this, as well as Dr. Rashika Fernanderpool. So here we have just guest after guest on the show, basically saying the same thing. If you actually want to have a mission return rate, there must be Dyad leadership here. And you gave a number of different things for what that could look like. But ultimately, at the end of the day, it's going to be some kind of roll up, whole patient, not just the well patients, but also the patients that are pretty sick and require a bunch of time.
Stacey, that's so well said. I mean, when I started, I was head of service lines in a hospital that was losing $20 million a year. And I said, we need Dyad leadership, right? You got to have the mission side, you got to have the margin side. There's got to be a meeting in the middle.
Dyad leadership, by the way, means when you have a clinical lead, which might be a nurse or other clinician, it doesn't have to be a physician, but this individual is a co-leader with someone on the finance or business side. And neither of those roles, by the way, is ornamental and just for the marketing. Both have actual decision-making authority. I would also listen to episode 492 with Shane Cerrone and Dr. Sam Flanders, where everybody in an organization helps solve problems. This is another spin on Dyad leadership or an extension of Dyad leadership.
There's got to be common ground here. We can't be all of one or all of nothing. So most of the problem with our money loss was physicians didn't feel like they really needed to bill for their services. They didn't really feel like they needed to see more than one patient hour. They felt like they were, that the state should continue to subsidize us and we should just be special because we care for kids. That was kind of the mentality as a physician that had to come in and say, this isn't going to work. You got no margin. You're not going to be here. Like you can be as Pollyanna as you want on the mission, but there has to be something more in there. Like seeing 10 patients a day instead of 20 patients a day. Well, is it really going to be a lasting way to kind of get this done if you really are about the mission? Because we often talk about being mission driven, but I don't really want those phone calls. I don't really want to text that family. Oh, that, you know what I mean? Like, let's not be like one-sided here. I get it on both sides of the physician side. We are human, just like the financial people are human. To your point, everybody kind of has their play. And I do pick on physicians. I've done a lot of business, so I've learned a lot, but I've also always fallen back on, I'm really a physician. I'm not going to make the greatest business decisions. Me getting an MBA is kind of, silly. Like we need to embrace the fact that we need teams in our care delivery systems. We don't need hierarchies. We need more team-based kind of care. The same with the CEO and the finance people. If they're not listening to the physicians, if they're not coming down to the ER or the clinic or seeing what the impact of their Excel spreadsheet manipulations are doing to patient care and how everything affects everything, until we kind of get some of that mission back, some of that cost accounting, some of that decreasing the variation, that non-revenue focus and mission focus, like, man, I am so tired of seeing kids significantly ill going to the ICU because they don't have a primary care doctor. Most of the time in the ER that I see, it's kids that don't have their medications or they don't know how to take them, right? Because we prescribe them and send them on the way. It's just mind-boggling kind of to that whole ripple effect of total cost of care. I mean, if you talk to pediatricians, they'll be like, well, patients don't want to learn. Patients just don't want to do what they want to do. Like, if you talk to the patients, they're like, I can't get a hold of my physician. He doesn't listen to me. All this mistrust that kind of fosters this. And I think we have to take our accountability that how much margin do you really need? Where's it go?
Yeah. I mean, it is mission that puts the care in healthcare. And if patients feel like they are seeking healthcare and they get a visit which is devoid of feeling cared for, then certainly you get to the place where, to your point, that we are, where there is, everybody thinks that the doctor standing in front of them, which is pains my heart, is doing things to make money. You get this plummeting trust with everyone within the system. And there's a bunch of different polls that show this bearing out. I think hospitals are some of the least trusted. They're coming in right behind insurance carriers, the most untrusted organization across the country. And that definitely has a spillover effect. So there's some work to be done here because it's the mission side of the equation that fixes that.
I think everything's a pendulum. I've seen over the 30-year, my career started as fee-for-service started. When I started, we didn't even know what a CPT code was. We didn't really bill. We checked everything as a level 2. And then the coders came in and started to train us. Now we don't even see the billing. The billers do it, right? I mean, it's just very interesting to see how fragmented we've become in healthcare, how margin-driven we've become, and everybody's miserable. Like it's like, I don't know who's happy. Maybe the high margin, high salary people are really happy. I mean, I know CEO salaries have grown 100% in 10 years, whereas physicians have decreased. But, heck, I'm a pediatrician. If I wanted to be rich, this would be the last thing I would have chosen. It's kind of some of that dummy stuff of like, oh, I'm idealistic. I want to take care of kids. I want to give kids better care. And yet you're making it so hard for me to do it. Like, I don't get it. I already make less than a tenth of what you make. I'm hoping that through these discussions like that you have on this podcast, that people can see another side that, hey, margin is great and invest is great and selling in 7 years is great and 10 times. And hey, I make a lot as a physician, so I'm going to do real estate and that. Like at some point, we got to figure out how we can get some of these dollars to flow back into the mission and get back some of the trust that we've lost if we're just focused on margin. And I think we need that pendulum to edge back the other way.
Dr. Mick Connors, if someone is interested in learning more about your work, where would you direct them?
I've got 2 newsletters on LinkedIn. One is about transforming pediatrics, and the other is just what the doctor sees.
J. Michael Connors, MD, on LinkedIn. I would highly recommend to follow. Dr. Mick Connors, thank you so much for being on Relentless Health Value today.
Thanks, Stacey, and thanks for your podcast, everything that you're doing. I think it's phenomenal. Just, gosh, we need more perspectives, more dialogue. I certainly don't have the answers, but it's fun to learn from you and from those that you have on as well.
Hi, I'm Dr. Vivian Ho. I'm a health economist at Rice University and Baylor College of Medicine. I listen to Relentless Health Value religiously because this is the show for those who are part of the tribe that wants to improve the quality of healthcare, improve access to care, and make it affordable. So make sure that you subscribe to the newsletter and subscribe to the podcast and keep up with every episode.